Good afternoon, or good morning, or good evening, depending on where you're listening from. I'm Dr. John Iskander. On behalf of CDC, I'd like to welcome you to April's Public Health Grand Rounds. Continuing education credits for Public Health Grand Rounds are available for physicians, nurses, pharmacists, health educators, and other health professionals. Please see more at the Grand Rounds website. Grand Rounds is also available on all of your favorite web and social media sites. We have a featured video segment on YouTube called Beyond the Data, which is posted shortly after the session. This month's segment features my interview with Deputy Surgeon General Boris Lushniak. We're also live tweeting today, so please use hashtag CDC Grand Rounds for all your tweeting needs. For those of you interested in related topics, many of the people involved in putting this session were also involved in writing up an article recently published in CDC's MMWR on the future of cancer screening. Please look for that online. Today's speakers include not only the current deputy and former acting surgeon general, but an actual surgeon. I think that's a first. It's our pleasure and privilege to work closely with our speakers to bring you these sessions each month. I commonly introduce our speakers as public health heroes in recognition of the coming May summer action movie season. You'll see that we have actually some superheroes in today's session as well. We've partnered with the CDC Public Health Library and Information Center to feature scientific articles relevant to the session. The full listing is at cdc.gov/scienceclips. Here's a preview of upcoming Grand Round sessions. Please join us live or on the web at your convenience. It's now my pleasure to introduce Admiral Robin Accredit, CDC's Deputy Director for Non-Communicable Diseases, Injury, and Environmental Health.
Thank you and good afternoon. We're delighted that you could join us this afternoon. Skin cancer is one of the most commonly diagnosed cancers in the United States, yet most cases are preventable. While rates of other cancers are decreasing, the rates of skin cancer are increasing, creating a serious public health concern that we cannot ignore. Melanoma, the deadliest form of skin cancer, is also one of the most common cancers among U.S. adolescents and young adults. Although those with lighter skin are more at risk, anyone can get skin cancer, and it can be serious, disfiguring, and even deadly. Ultraviolet or UV radiation is the most preventable cause of skin cancer. The most common types of skin cancer are strongly associated with exposure to UV radiation. Tan skin is a sign of damaged skin, not health. When people tan or get sunburned, they increase their risk of getting skin cancer. There is no evidence that indoor tanning is safer than tanning outdoors or provides any protection for further sun exposure. Indoor tanning is risky behavior, yet 1 out of every 3 young white high school girls reported indoor tanning in 2012. The Surgeon General's call to action to prevent skin cancer was released last July, and it creates a plan for multiple sectors to take an active role in preventing skin cancer. As you heard, we're honored today to have with us the U.S. Deputy Surgeon General, Boris Lushniak, under whose leadership as Acting Surgeon General, the call to action was released. Schools and early learning centers, colleges and universities, employers and employees, healthcare systems, insurers, and clinicians can all take an active role in protecting communities and individuals from the harms of excessive natural and artificial UV radiation exposure. Today, you'll hear case studies and examples of these policies and personal actions in the session. Today, we'll hear about innovative efforts at the federal, state, and local level that are raising awareness about the increasing tide of skin cancers. These efforts include bringing partners together across federal agencies and in communities to address risk factors for skin cancer, intervene using proven, effective tools, and accelerate their progress over time. 2 of our speakers today come from heavily sun-exposed states, Arizona and Texas, that recognize the need to take action against skin cancer at the population level. To reduce skin cancers in the population, people must get the information they need to make informed choices about sun protection. Policies must support these efforts, and youth must be protected from the harms of indoor tanning. Achieving these goals will not be a small task. It will require dedication, ingenuity, skill, and the concerted efforts of many partners in prevention across many different sectors. Many of these partners are already enthusiastically involved, but greater cooperation and support are needed to increase their reach of these efforts. We must act with urgency to stop the ever-increasing incidence of skin cancers in the United States. Thank you.
Thank you, Admiral Ikeda. Our first speaker is Meg Watson.
Skin cancer begins in the cells of the skin. There are three most common types of skin cancer, and in order of incidence, those are basal cell carcinomas, squamous cell carcinomas, and melanomas. Basal cell carcinomas alone are thought to be the most common type of cancer. Melanomas originate in the cells that make melanin, the pigment that gives skin its color, and it's the most deadly of the three common types of skin cancer. Skin cancer is associated with a significant public health burden. Estimates from medical expenditures show that nearly 5 million skin cancers are treated in the U.S. each year. About 65,000 malignant melanomas were diagnosed in 2011, and there were about 9,000 deaths due to the disease in that year. There are also about 3,000 deaths due to non-melanoma skin cancers each year, including some deaths from squamous cell carcinomas and from some rare types of skin cancer. Cancer registries collect information on melanomas, but not on the more common basal and squamous cell carcinomas, so incidence data on melanomas will be presented here. This slide shows invasive melanoma incidence data from the National Cancer Institute's SEER program. Incidence of melanoma, as you can see from the slide, it's been increasing since at least the 1970s. Incidence rates are higher overall for males, but have been increasing consistently for both sexes. We've seen overall incidence roughly triple over the last 2 generations, with an average annual percentage increase of about 3% each year. This slide shows aggregated data on invasive melanoma incidence over a 5-year period, and this data is from CDC's National Program of Cancer Registries and NCI's SEER program, which combined cover the entire United States. Melanoma is most common among older men, and it's higher among men than women, starting at about age 50. However, rates among adolescents and young adults are higher among females than males. Melanoma is the second most common cancer among women in their 20s. This is likely related to intentional tanning, either outdoors or indoors. You hear much more about this problem and how it's being addressed by subsequent speakers. And skin cancer is costly. Treatment for skin cancer costs $8.1 billion each year in the United States, and annual costs more than doubled between the periods 2002 to 2006 and 2007 to 2011. Genetics has a strong effect on skin cancer risk. Having light hair and eyes, fair skin, skin that burns or freckles, or certain types or a large number of moles increases the risk of skin cancer, as does having a family or a previous personal history of skin cancer. Although those with lighter skin are at higher risk, people with darker skin may often be diagnosed later, making it more difficult to treat. This slide again shows data from NCI and CDC combined and shows melanoma rates by race and Hispanic ethnicity. Non-Hispanic whites have about 25 times the rate of melanoma compared to blacks and about 6 times the rate of Hispanics. Rates are higher among males of all races and ethnicities except among blacks, for whom differences by gender are not statistically significant. These differences are primarily related to differences in skin type. Melanin is produced in the skin, and it gives skin its color, and it's also protective against UV radiation, so darker skin has more protection. However, it's important to remember that there's wide variability in skin types and in sun sensitivity within racial and ethnic groups. Despite the importance of skin type and non-modifiable risk factors, public health efforts focus on UV radiation exposure because it's the most preventable cause of skin cancer. Between 65 and 90% of skin cancers are thought to be caused, at least in part, by UV radiation. UV from sunlight is the most common source of exposure, but some people are exposed to artificial sources of UV, either from cosmetic indoor tanning, medical treatment, or less commonly, occupational exposures. UV damages the skin cell's DNA. The lag time between exposure to UV and development of cancer is thought to be about 10 to 20 years, but in some cases, this time period appears to be much shorter. And UV varies by wavelength. UVA penetrates more deeply into the skin than UVB, and both can cause cancer. The term broad-spectrum protection means that products such as sunscreen protect against both types of UV rays. Tans and sunburns are reactions to damage from UV. Although tanning provides a small amount of protection against future burns, it also indicates that damage has occurred. Sunburns indicate that cell death has occurred. In national surveys and research studies, sunburns are often used as indicators of UV exposure because they take into account individual sensitivity to UV rather than just exposure time. Rates of sunburn remain high, with about 37% of Americans reporting getting burned every year. And among those who report burning, many get burned frequently, defined here as 4 or more times in the past year. UV damage adds up over time. Sunburns and overexposure in childhood and in adulthood can increase risk. It's not surprising that with high sunburn rates, there's room for improvement in use of sun protection. Although nearly 70% of adults report always or usually protecting themselves from the sun when outdoors for more than an hour on a sunny day, a closer look at methods of protection tells us a different story. You can see that use of each individual method of protection is quite a bit lower, particularly using a wide-brimmed hat or a long-sleeve shirt. Protection also differs by gender, with women primarily seeking shade or using sunscreen, and men reporting wearing long clothing to the ankles as their most common method of protection. A national survey asking high school students about sunscreen found that only 10% of students reported wearing sunscreen when outdoors on a sunny day for more than an hour, and that's 13% of females and only 7% of males. Unfortunately, this is not the only behavior that puts youth at risk from skin cancer. Indoor tanning exposes users to intense UV to tan the skin for cosmetic purposes. This intense UV increases the risk of skin cancer. One study recently estimated that about 400,000 cases of skin cancer in the United States could be caused by indoor tanning each year, including over 6,000 melanomas. And indoor tanning is common among some groups. Tanning rates are highest among non-Hispanic white women and peak from about age 16 to age 25. Almost 1 in 3 of these women report indoor tanning in the past year. The Food and Drug Administration warns against indoor tanning by people younger than age 18, and 11 states currently prohibit tanning by minors. Recent estimates suggest that about 1.6 million high school students younger than age 18 are tanning in the U.S. each year. So, what works to prevent skin cancer? Reducing overexposure to UV reduces rates of skin cancer in the population, but how do we get there? Because of the long lag time and large populations required to detect cancer outcomes, intervention effectiveness is usually measured by intermediate outcomes, such as reductions in sunburn or indoor tanning, or by increases in sun protection. Based on these outcomes, the Community Guide has recommended several interventions. Multi-component community-wide interventions are defined as at least 2 interventions implemented in at least 2 different types of settings. So, for example, a school sun safety education program combined with a mass media campaign in a community. The most comprehensive examples of this type are from Australia. Education and policy interventions have been demonstrated to be effective in schools from early childhood up to 8th grade, as well as in outdoor recreational and occupational settings. The U.S. Preventive Services Task Force has recommended provider counseling about minimizing exposure to UV for fair-skinned patients aged 10 to 24. The task force has currently found insufficient evidence to recommend provider screening for the general population In other words, clinical examination of the skin in the absence of symptoms for patients at average risk. The task force is currently re-reviewing the evidence on skin cancer screening. Time and cost are key barriers to assessing cancer outcomes through randomized trials, but there are some new studies regarding skin cancer screening which are going to be included in the updated review. Based on the existing evidence, Acting Surgeon General Boris Lushniak issued a call to action to prevent skin cancer last year on July 29, 2014. CDC worked closely with the Office of the Surgeon General to develop the document. Based on the current evidence, the Surgeon General outlined 5 broad, overarching goals to prevent future cases of skin cancer. The first goal aims to increase opportunities for sun protection while outdoors in settings like recreational areas and schools. The second goal addresses communications about skin cancer prevention and the need to identify and disseminate effective prevention messages. The third goal relates to policies across all levels, from federal to state and local, and it includes organizational policies as well as legislative. For example, school policies can help support skin cancer prevention in a number of ways. The fourth goal relates to reducing harms from indoor tanning, and the fifth goal relates to strengthening research and increasing our understanding of how best to prevent skin cancers in the future. Thank you, and the next speaker will be Sharon McKenna from the Arizona Department of Health.
Thank you, Meg. It's exciting to be here today to share with you my personal experience implementing sun safety. I became a sun safety advocate in 2002 after my first melanoma diagnosis. A clinical trial nurse urged me to contact the state health department because of my background as a former reporter, editor, and publicist. I told her after my diagnosis, I was stunned to learn that childhood exposure to ultraviolet radiation has a huge impact on whether a person will develop skin cancer. I took her advice. I met with the health department, and shortly after, I was given the job opportunity of a lifetime to create and implement a sun safety program. It was a grassroots door-to-door effort, starting with my then kindergartner's school. I called and asked for 10 minutes to speak about sun safety during a staff meeting. I phoned school after school requesting the same thing, and those 10-minute talks led to an hour-long presentation. And today, I can give about 300 school presentations across our state. I get paid to obsess about my affliction. After 31 biopsies, lesions, and diagnoses of all 3 forms of skin cancer, I am one among millions of skin cancer patients who likely had no idea that skin cancer is the most common, yet most preventable of all cancers. Arizona, where I'm from, if a country, would rank number 2 in the world in skin cancer incidence. And we have over 300 sunny days. Our warm climate allows us to wear t-shirts and shorts in winter, resulting in greater year-round exposure than in some colder climates. We were able to bring attention to sun safety, which enabled our agency to make it a top priority. Every time I go out, every outreach activity performed, every email I send, every potential partner I approach is asked to share our sun safety message, embrace it, and adopt it. As Meg mentioned, state cancer registries collect melanoma data. Arizona's invasive melanoma rate is somewhat higher than the national rate, but we in the field felt that our rates were maybe a little bit lower than we expected. So a melanoma task force was formed to compare the number of cases received by our registry with the number of cases logged within individual dermatology practices. By comparing cases reported to cases treated, we found an unreported rate of 70%. Now, we are cleaning the past 14 years of melanoma data, collecting it from the state's 531 dermatologists. We've revised the melanoma reporting form. We've created a monthly newsletter focused on helping providers improve reporting requirements. And once that data is cleaned, we can map and rank Arizona in terms of highest to lowest melanoma rates. And while we can't yet pinpoint what causes one neighborhood in our state to have triple the melanoma rates of another, we can reach people in all 127 census-block neighborhoods simply by reporting our findings to the media so that everyone can learn how to protect themselves. We're proud that Arizona is the first state to pass a sun safety education mandate. Over 700,000 students in 1,100 K-8 schools learn how to protect their skin and prevent skin cancer. And private and non-traditional schools can also use the program voluntarily. And we form partnerships with over 250 organizations. Success in this state recently led the program's expansion to childcare sites. Under our Empower program, over 2,400 childcare providers are required to meet our sun safety standard with detailed protocols for applying sunscreen and providing outdoor shaded play areas. This program reaches 20,000 children ages birth through 12. And the great thing is, this is consistent with the Community Preventive Services Guide and the Surgeon General's call to action to prevent skin cancer. We're actually expanding through the sectors. So our initial goals were to protect kids and reduce UV exposure. We adapted the free EPA Sunwise program with easy-to-use curriculum activities that have backgrounds in science, math, and social studies that average 20 minutes and are categorized by grade level. We modified the curriculum to meet our state standards, wrote tip sheets, and created a physical education module to show kids how to be active outside and sun safe. We're turning sun safety messages into daily and lifelong habits. Sunburns and suntans can cause skin cancer, so use a broad spectrum sunscreen and lip balm with an SPF or sun protection factor of 15 or higher. Protect your eyes with sunglasses. Wear a hat with a wide brim. Seek shade under a tree, awning, or indoors, especially during peak midday sun. In Arizona, some offices have buckets of umbrellas so that you can use them while walking outdoors or from building to building to a meeting. We've asked that new schools be built to optimize the shadows and shade casts, especially during midday lunch recess. And some TV meteorologists announced the UV index, which tells us how much protection is needed to prevent sunburn and suntan on any given day. And of course, avoid sun lamps and tanning booths. Artificial sources of UV are just as dangerous as the sun's natural radiation. Simply keep your skin the color it was born in. We're helping schools expand their commitment to sun safety with strong policies. We provide a sun safety policy template to our 2,800 K-12 schools so that they don't have to create something from scratch. Our policies not only allow, but encourage sun safety practices because in some schools, wearing hats and using sunscreen is not allowed. Remember, the easier you make implementation for the people you're asking to do it, the sooner it will occur. We reiterate the Community Guide's recommendations. Primary sun safety school education is very effective in increasing sun protection among kids. In fact, our Arizona study of 281 K-8 school educators during a 7-year period found a 63% increase in student ability to provide examples of the harmful effects of the sun on skin. And that ability to provide examples is up 25% since we first asked the question in 2007. And 85% of our respondents cited Arizona as their primary source of sun safety education. As mentioned, we offer a policy template, and this is just a brief excerpt, just the first paragraph of a 2-page fill-in-the-blank policy that schools can use, adopt, or expand on if they wish. And we always recommend in creating a sun safety policy that you use the trusted educator and childcare sources that promote limiting sun safety policies among children. So phase 2, proliferate. The more successful you become, the more partners you'll attract, the more people you can reach. In 2003, the Phoenix Zoo allowed us to provide animal-themed tip sheets to patrons. That evolved into sun safety murals on bathroom walls, and now about 1,000 students this summer are able to get sunscreen and wide-brimmed hats as part of their sun safety uniform. Skin cancer has become a top 5 priority in programs I never dreamed possible, simply because I asked, came to the table armed with some compelling facts, and promised that we would support their efforts. A new Empower Schools program is being piloted for K-12 schools who receive USDA National Lunch Services, and this might be an opportunity for your states to someday incorporate sun safety. Supply people and partners with the knowledge and confidence to talk on this subject matter. We tweet, blog, provide updates, trends, and policies, much from the brilliant collaborators we work with here at CDC and around the world. We've learned a lot of lessons. I believe no only means not right now. Keep plugging away. Measure the processes and outcomes of your skin cancer efforts. I initially thought that contacting school superintendents would open the doors to sun safety education, but quickly found that approaching individual schools yielded much better results. And one sun safety assembly could lead to a statewide version of school district trainings. Use the tools you already have at your disposal and identify what data your state has already collected, for example, cancer registry data or BRFIS data, behavioral risk factor surveillance survey data that sometimes reveals adult sunburn behaviors. Policies can be effective at even the smallest level. Start with one intervention, one high-risk group who you have the greatest chance of reaching, and partner widely outside the public health sectors to reach people who don't yet know that sun and sun lamps can cause skin cancer. I remind students at the end of every assembly, you are my first generation of sun-safe kids. Now you know how to protect your skin and prevent skin cancer. Tell everybody what you've learned and be a role model. Tomorrow, I hope you'll email the Ground Round links to your friends, family, school nurse, and anyone you think could benefit from it with one short sentence that says, I think this information would be wonderful to include in an upcoming newsletter or blog. And I thank you for sharing the sun safety message and letting me talk today. Our next speaker is Dr. Jeff Gershenwald.
Good afternoon. I'm Jeff Gershenwald. I'm a surgical oncologist and medical director of the Melanoma and Skin Cancer Center at the University of Texas MD Anderson Cancer Center in Houston, Texas. In addition to an active clinical practice focused on melanoma, I also lead and participate in research on melanoma. I'd like to introduce you to a relatively new team science research program at MD Anderson called the Melanoma Moonshot. MD Anderson Cancer Center's Moonshot program aims to dramatically accelerate the pace of converting scientific discoveries into clinically impactful advances that reduce cancer deaths. I have the privilege of co-leading the Melanoma Moonshot with Mike Davis, a melanoma medical oncologist and physician scientist. We work with a large research team that represents many disciplines. Melanoma was chosen as one of MD Anderson's Moonshot programs because we have a very large clinical and research program and a clear vision with detailed goals and implementation plans. Our programs and leadership were considered to have significant potential to leverage advances in scientific knowledge towards maximal clinical impact and really making a difference for our patients and those who are not yet patients. More specifically, we know that when detected early, melanoma is treatable and often curable, but outcomes can vary widely across patients. Historically, for patients with advanced disease, there's been poor long-term survival. Nonetheless, recent advances have transformed our understanding of melanoma molecular biology and immunology, and these scientific advances have opened the door to targeted therapies and immunotherapies alike. Importantly, there's clear and compelling epidemiologic evidence that UV radiation, both from the sun and from indoor tanning devices, contributes to melanoma risk. The role of UV is also supported by recent research on genetic mutations in melanoma. Recent advances include work with the Melanoma Cancer Genome Atlas program, which I've had the privilege of co-leading over the last 5 years. Recent studies from the Cancer Genome Atlas program overall have shown that melanoma has the highest mutation rate of any cancer analyzed thus far to date. This Cancer Genome Atlas plot shows how often mutations occur. The plot shows about 40 tumor types arranged with increasing frequency according to the overall frequency of somatic or tumor-based mutations. Melanoma is at the extreme right. In this plot, each dot represents the frequency of mutations in an individual melanoma tumor. Taken together, we can see that melanoma has the highest frequency of mutations across this entire panel. Please also note the large, mostly yellow box below melanoma. This box is also color-coded to display the type of mutation, and in this particular graph, yellow indicates that most of the mutations are C to T transitions. Interestingly, the C to T transition pattern is classically associated with a UV signature. This provides further evidence for the role of UV radiation in melanoma. The goals of the melanoma moonshot are to reduce the incidence and increase the proportion of patients diagnosed with early stage, potentially curable melanoma, to personalize management strategies in clinically localized melanoma, and to improve long-term disease control and survival in advanced melanoma through personalized treatment approaches. There are two initial flagship projects. The first involves primary prevention of melanoma through UV radiation protection in youth, led by Mary Tripp, Susan Peterson, and Ellen Gritz of the Department of Behavioral Sciences. The second will involve integrated analyses and targeting of key cancer genes and the anti-tumor immune response to better personalize care and to increase long-term survival in melanoma. I lead this latter project with Mike Davis. We'll focus on the melanoma prevention flagship, which focuses on working with youth and increasing their use of UV protection, decreasing their sun exposure, and decreasing their tanning behavior. These objectives can help achieve the long-term goal of reducing the incidence of melanoma. And the project includes activities to support, facilitate, and evaluate legislative activities and maximize reach and impact of evidence-based interventions. The prevention flagship will initially focus on primary prevention of melanoma across the age continuum. Initial efforts have focused on evidence-based curriculum development, dissemination, and implementation for pre-K, with similar activities planned for kindergarten through second grade. A UV photography protocol is being targeted to middle school students that we'll talk about in just a moment. And we'll soon embark on indoor tanning facility legislation compliance and research efforts that, as noted by Meg, targets behaviors common in high school. Finally, I'll introduce a skin cancer prevention toolkit initiative that's being developed for colleges and universities. The aim of the preschool curriculum is to teach children about sun protection and to promote safe behaviors in an effort to reduce the child's chance of developing skin cancer later in life. This is a theme-based curriculum where sun protection, for example, is actually a superpower. The central idea is that the superhero characters travel around the world, and each character has a sun-safe superpower to protect him or herself against the harmful effects of the sun's rays. In the center here is Ray, and he's part of Ray and the Sunbeatables. Ray is the leader. He's in the center and has a superpower of shade, and he also knows when it's safe to be outdoors. Ray wears a magic watch that reminds him to be super protected from 10 a.m. to 4 p.m. when the sun's rays are most harmful. From left to right here, Chloe, Serena, Stefan, and Hannah have in order superpowers of protective clothing, sunscreen, protective sunglasses, and protective hats. Our strategy includes MD Anderson's recently announced collaboration with the CATCH Global Foundation, an acronym for Coordinated Approach to Child Health. CATCH includes programs for early childhood education, elementary school, middle school, and after-school programs, and each includes components for nutrition, physical education, classroom, and community and family outreach alike. The original CATCH study was the largest school-based health promotion study ever conducted in the United States. CATCH has a history of 25 years of research and real-world implementation and currently reaches approximately 50% of Texas school districts. We're also expanding our curriculum for K through second grade. Consistent with the Surgeon General's call to action goals, the curriculum emphasizes providing individuals with the information they need to make informed, healthy choices about ultraviolet radiation exposure. We have aligned these activities to the state standards as well as the Common Core and national standards. As a component of the melanoma moonshot, MD Anderson used its experience to help educate and inform legislators in Texas about the link between indoor tanning and skin cancer. In 2013, Texas legislators passed SB 329, which prohibits indoor tanning bed use for persons under 18 years of age. Texas was the fourth state in the United States to enact such a law. And this was really a tremendous effort, collaborative across the Cancer Prevention and Control Platform at MD Anderson, our government relations team, multiple medical societies, foundations, and several of our patients. By 2014, there were 11 states that had passed under 18 tanning bed prohibitions, and we're actively involved now in providing technical assistance and education across other states that are considering similar legislation. MD Anderson has continued to use its experience to help and support similar efforts in 9 other states to date, from coast to coast, including Arizona, where Sharon comes from. Understanding how the legislation is implemented and how well tanning facilities comply with the ban is a critical next step. We'll begin a new study to determine the proportion of Texas tanning facilities that comply with SB 329 soon. We'll be examining compliance among 1,100 facilities licensed by the Texas Department of State Health Services. There have been some recent changes in the regulation of indoor tanning devices in the United States that also provide some important opportunities for prevention. The FDA recently changed the classification of indoor tanning devices from Class 1 device, as shown here, prior to May of 2014, to a Class 2 device as of May of 2014. This is remarkable because previously, as you can see here, tanning beds were in the same category as tongue depressors and elastic bandages like Band-Aids. Changing the classification to Class 2 devices has meant that tanning beds are now included with X-ray machines and other specialty UV lamps for dermatologic disorders. The FDA also issued a black box warning required for use on tanning devices that states, this sun lamp product should not be used on persons under the age of 18 years. To leverage these prevention opportunities, we're reaching out to the medical community on issues related to indoor tanning. One example of this is a recently published editorial in the March issue of the Annals of Surgical Oncology. This editorial highlights the importance of educating policymakers about the harmful effects of artificial UV exposure for youth, and also to highlight the FDA's recent black box warning. Can we improve sun protection in adolescents? Recent research has examined appearance-focused interventions to reduce indoor tanning and sun exposure behaviors. UV photography is being used as a potential appearance-focused intervention to increase sun protection behavior and decrease sunbathing and indoor tanning intentions in adults. Our moonshot will conduct a study to examine the effects of this intervention for adolescents in middle schools. The intervention involves taking a standard and UV photo of the face using a camera with a UV filter that provides an image representation of skin damage due to UV radiation exposure. We'll study whether this intervention is effective at increasing adolescent sun protection behaviors and whether it acts to decrease tanning behaviors and sunburns. I also want to mention our work related to college and university campuses. The Skin Cancer Prevention Toolkit is in development and through a partnership with the American Cancer Society Cancer Action Network. Our goal is to make advances in eliminating indoor tanning devices from colleges and university campuses. The toolkit will provide resources and tools for higher education administrators to adopt skin cancer prevention policies and commit to eliminating student use of indoor tanning devices. The toolkit will include a comprehensive collection of facts, policy templates, education, and resources to implement skin cancer prevention efforts on campus. I'd like to acknowledge the multidisciplinary team that is such an integral part of our melanoma moonshot. Liz Burton is our scientific project director. As I mentioned before, Mary, Susan, and Ellen led and currently lead our prevention flagship. Pyle and Mandy Joe on the right here are the program managers for our prevention flagship. And Ernie Hawk and Mark Moreno lead the Moonshot Cancer Prevention and Control Platform. Finally, as I thank you for your attention, I'd also like to acknowledge the generous support of the multiple individuals who have thus far made the Melanoma Moonshot possible. I'd now like to introduce Deputy Surgeon General Boris Lushniak.
Thank you, Jeff. And I'm here to be the closer. It's kind of interesting how this is very much akin to what goes on with the issuing of a call to action. Meg was very kind in terms of saying, well, CDC approached the Office of the Surgeon General and we kind of helped out. Let me tell you the truth. Right? The truth with Surgeon General's reports and calls to action is all, if not most of the work is done by others. That's the truth. And in this case, we have an incredible partnership with CDC in issuing this call to action. But I give kudos to Meg, to the whole team that worked on this call to action. Because ultimately, it's akin to what we have in the football game. I'm not a big sports guy, but in the football game, right, when you start advancing the ball from your own 1-yard line, all this work is done. And that's the way I view a call to action. All this work is done, in this case, by CDC, by several of our other partners that I'll go to quickly. But at the end, they bring it down to the 1-yard line. And then the fancy guy in the fancy uniform gets to score the touchdown, right? That's the photo image. And at the end of that, it's back to the concept of the Surgeon General's office being the bully pulpit, right? That we come out there in the uniform and say, listen, America, this is what needs to be done with skin cancer prevention. Photo ops are taken, you get the interviews, but I'm the first to acknowledge that a lot of the work, the grunt work, the pushing of that ball ahead took place by many others. So what do we know? I'm the finisher here in this esteemed panel as well. So I'm at the 1-yard line taking the ability to put all this together yet again. Lucky guy in the uniform. But in fact, what we epitomize here in front of you is in fact how we advance the ball in public health. Notice the partnerships here at this very table. It started out with the feds, the CDC approach. We ended up at the state, an activist approach. And then the world of a medical, prevention, and academic approach to this. And then we bring in the bully pulpit, the ability for the Surgeon General's office to be represented and say, here's where we should be heading. So it is a major public health problem. We've talked already about the increasing disease burden, the costs, the rates of skin cancer being a problem, a public health problem in this United States, one that we can't ignore. And once again, the ability for us to put all this together to say, now's the time to advance it. We're in the 21st century, and we're discussing with Jeff earlier today, saying in the 21st century, if there's anything that we've learned, is the ability that we will do better in diagnostics, we will do better in therapeutics, but ultimately the answer to so many of our national problems, including skin cancer, is the prevention side of the house. That's where we have to get better. And how are we going to do this? Through these types of partnerships, community partners, business leaders, government agencies, individuals uniting around a common cause. Now this document, which I'll refer to several times, the call to action, why did it take place? You know, when I go back in time, and Meg was at that meeting, it was Dr. Howard Koh, then the Assistant Secretary for Health, by the way, also a person who has dermatological training and is interested in this subject matter. In the room is the Deputy Surgeon General, who happens to be a dermatologist and interested in this subject matter, and an interested party in CDC. And we walked away from that meeting 2+ years ago now saying, we can do this. As happened, that deputy became the acting, and things moved much more quickly. But it's really what it is a call to action. I love that term because it's not a Surgeon General's report. It's not just coming out there and saying, here's all the facts. It's in essence saying, we have more work to do in this arena. A science-based document, right? It's to stimulate that action nationwide to solve this problem. It raises awareness. Because as Brian Williams, now a controversial figure, on the nightly news that very night of the release, looking sternly into the camera, a tanned Brian Williams, mind you, and said these words, in the 143-year history of the Office of the Surgeon General, this has never happened. And what happened was an awareness. It's not like we changed the world by putting out the information, the call to action. A lot of this was already known. It's the fact that it ended up in the hands for that last yard for a message to come from a messenger that for the longest time was not talking about this issue. Yes, there's a million issues in public health we can talk about, but that was all about time and place. In the 143-year history of the Office of the Surgeon General, this has never happened. So So it provides clear action steps to move forward on this subject matter. Now, the partnerships that exist out there, again, government-wide and beyond government. An important role here is the National Council on Skin Cancer Prevention that brings multiple organizations together, that waves the flag of skin cancer awareness and prevention. And partnerships with groups like the American Cancer Society, the American Academy of Dermatology, and now after the report was issued, even more so, the important impetus that the work is not just done by the feds here. You know, long ago that we've dissipated or gone beyond the sense of, oh, we're the feds, we're in charge, we can do it all. No, nothing moves in public health until we establish those partnerships, and many of our partners are shown here on this slide. It begins at the local level. One of the first things I did after the issuing of this report is we went down to do a meeting down in New Mexico. And outside of Albuquerque, or in Albuquerque, at Bandelier Elementary School, was a sense of what could be done. And this was much like your story, right? It was the sense that at an activist level, it was parents years ago saying, you know, we have an issue in New Mexico, and our kids are playing in these areas that don't have shade. And yes, there was resistance. Yes, there was this inability to make things happen quickly. But ultimately it happened. Now you have this whole school that's really dedicated to teaching kids about playing is important. Being outside is important. But taking care and preventing damage from ultraviolet radiation is just as important. You know, there's almost a rite of passage in this student population. As new kindergartners would come in, the older kids, right, the big kids on campus, the 6th graders, would turn to the younger kids, and they would be the ones issuing the sun protective hat. It was welcome to the school. This is what we do here. And I love this photograph because partially you would say, as a photographer, oh, there's too much shade in that photograph. But in fact, it's shady for a reason, folks. And notice that the only person not fully protected is the acting Surgeon General at the time. He has a short sleeve shirt on and not a very protective head cover. So what do we do? In terms of the strategies, we heard from Meg earlier today about the strategies. In terms of call to action, what do? We talk about what we've done already. Incorporate sun safety education policies in school. Support that shade planning in land use development. Yes, this is where groups like architects and planning association and parks and recreation people play a role in partnerships in public health. You know, I grew up at NIOSH, right? And in that world of occupational safety and health, yes, there's a role there of protecting those outdoor workers from that very same exposure. And certainly looking at the indoor tanning laws, as already described, it's a key feature. We have an industry out there that's selling a known carcinogen to a vulnerable population. Well, what the hell are we doing about it? Right? What are we able to move ahead on in terms of protecting people, providing to them the right information? Yeah, I'm not here to overregulate everybody, but at the end of the day is how many of those young kids who are going to tanning booths realize that this is a known carcinogen that will be problematic. And certainly providers, their role in terms of counseling patients and hopefully making breakthroughs with further information about screening and its ability to play a role in terms of prevention. So millions of teens are exposing themselves to this unprotected ultraviolet radiation. And yes, there are changes in motion. World Health Organization, 2009, this is a known carcinogen. We heard about the FDA changes in terms of their regulatory approach as a Class 2 device. We certainly have interest in Congress, right, looking at groups that exist out there that in fact are supporting an exposure to a known carcinogen. But let's be honest here, you know, none of us volunteers to say, hey, listen, I want to go out this weekend and get a sunburn. Right? Nobody says that. Sunburn is bad. And yet, how many circumstances is it? You know, I was going through this with John earlier on the Vital Signs videotape today, is how many times do we return from a vacation and say, oh man, you look great, you look tanned. In essence, tanning is a sign of skin damage. And you look at the concept of tanning, whether natural light or artificial light, it is being condoned. Right? Here's an example at UNC. 26% of Chapel Hill, North Carolina apartment complexes provide indoor tanning facilities to their renters. You know, we've made headway in smoking. No smoking allowed in the building, right? Because that's a known carcinogen, secondhand smoke. But I have a tanning booth here. Here, enjoy. To some extent, we changed the social norms on smoking. And the same thing needs to take place with other known carcinogens. Certainly positive is that rates of indoor tanning have been falling. 2009, 2013, we see some declines. Our hope is that we're seeing some sort of effect from this increased awareness. Certainly, we look back at 2009 and realize that when we look at indoor tanning restrictions for those under 18, there was only some restrictions in a couple of states. We moved to 2012. By 2012, California became the first state to prohibit indoor tanning for all minors younger than 18. Vermont then implemented an under 18 ban in that same year. And then we move ahead now to 2014 and 15. Notice blue is good here. 42 states have implemented new laws of strengthened existing laws about indoor tanning amongst those minors. So in essence, we are pushing ahead and making this better from a policy perspective. And how does that then translate to an effect on health? Well, we know in states that have those multiple youth restrictions, with youth access restrictions, the odds of indoor tanning among teen girls were 42% less. And now our hope is that's going to be translated to a decrease of that burden of disease. And still, we still have this concept of the social norms. Even beyond the indoor tanning, more than 1 in 3 Americans report getting sunburn each year. Okay, so who here got sunburn in the last year? Raise your hands. Guess what? The Deputy Surgeon General did too. So I blew it, right? I blew it. But the reality is that's not a good thing. We have to have that sense of awareness when we're outdoors. And we condone from the Office of the Surgeon General, go out, have a good time. It's about physical fitness. It's about getting outdoors. It's about bicycling and kayaking and swimming and running and walking. But protect yourself from that known carcinogen. And certainly when it comes to indoor tanning, once again, we have to look at it for a fact. It's an industry that is selling a known carcinogen. So overall, we still have a lot to do in the realm of health communication and health education. So the next steps, we continue on this pathway using the call to action. I ask you all, look it up online, look through it, implement it into your own lives. Certainly we at CDC have to be those examples for a healthy life, an active life, but a healthy life. Comprehensive community-wide efforts to prevent skin cancer can work, and with adequate support and a unified approach, we will be successful. And we look at success stories out there, right? We looked at the ability for Arizona to turn the tide. We looked at the ability for MD Anderson to be able to implement laws within the state of Texas. We look internationally, right? Community programs within SunSmart in Australia shows that skin cancer prevention saves lives and saves money. Every dollar invested in SunSmart Australia saves more than double in healthcare costs in that nation. So I finished where I started, right? The guy in uniform passing this message through on that last 1 yard line. I thank you first and foremost for your attention, for being here. I thank you for organizing all this, CDC. But most importantly, the message really is take care of ourselves. Summertime, it's a beautiful spring day here. Summertime's around the corner. Just be careful with your skin. And one of the images I didn't portray here, but I just spent 2 months commanding our Monrovia Medical Unit in Liberia. And one of the photographs I have is in the midst of the Ebola crisis. Right? Our officers go into the hot zone fully covered, protecting themselves against this microbe, this deadly biologic agent. And that's not how I want them to protect themselves against ultraviolet radiation. But at the same time, the other imagery I have is of those same officers in the very hot Liberian sun putting on their sunscreen. Yes, rolling down their sleeves on their field uniforms. Yes, wearing the goofy boonie hats which provide shade. Right, that's the image that at the same time you protect yourself from Ebola, you're also protecting yourself from ultraviolet radiation. It is doable by all of us. I thank you so much for your attention. change the slide.
Thank you, Admiral Lushniak. We'll now open the floor for questions. I think we've got about 5 minutes. If you're in the room or online, please remember to keep your questions brief so we have time to answer as many questions as possible.
We have a question from our online audience for Admiral Lushniak. You mentioned that tan skin is a sign of damaged skin, and yet artificial tanning has become a part of societal norms. What can we do individually and as a society to change the norms and behaviors?
You know, to a large extent, we almost have to look back at the tobacco situation. You know, what helped us with tobacco with social norms was, in fact, what? Not so much the messaging on tobacco itself, it was the messaging ultimately on secondhand smoke. It's when it became a bigger issue, saying, hey, listen, when you light up, you bother me. I don't think we're going to see that issue, you know, or that help coming out of the skin cancer world. I think part of it is the idea of from a health communication aspect and a health literacy aspect. You know, we throw in the issue of disparities. How do we get messaging out when things are not good for people? And I think that's the approach we need to look at this, which is it's a health communication endeavor, which is how do we sell this idea that this is a known carcinogen? From several perspectives, one of which is we know that certainly in the teen and young adult population, the concept of skin cancer is not necessary. We've tried this with tobacco. Oh, you're going to die of cancer, don't light up. That message doesn't work. But it's utilizing other effects, right, which is, you know, everyone's deathly afraid. So why do you tan? Okay, so I have 2 daughters. A couple of weeks ago, we're vacationing in Key West. Both of them are like lying out. But Dad, you know, we want to look pretty because the prom's coming up. Right? Even the acting or the deputy surgeon general has that issue. And ultimately, I'm still battling that. But the sense is, guess what? You know, this prettiness, quote unquote prettiness in the short run, is not, you know, I'm not bringing out the cancer thing yet, but I'm saying, you know, listen, you want to have really ugly skin, right? It's going to happen quickly. You want to be wrinkled and appear, you know, older than you are. So my younger child has bought off on this. She is proud that her skin is actually very pale and pretty. And I'm working on my older one, so when you figure it out, let me know.
Do we have any other questions in the room or online?
Yes, another question from our online audience. If you build a slow tan using the tanning bed so that you won't burn out when outside, is that worse than burning?
I'll tackle it initially, and maybe we can go to the, you know, the reality is that, you know, this idea of having a protective tan. So, you know, it was actually common for a while there. I'm not sure how common it is, which is, hey, I'm heading off on this cruise. I'm going to do a few sessions so that I don't burn. Yeah, there is a protective effect. The SPF factor of a tan is on the order of 2 to 6. So even though you think you're out there protecting yourself, the reality is you're just allowing yourself to actually have excessive ultraviolet exposure even more on that trip. It'll be protective for a fact. You still can break through with a burn based upon your exposure, and it gives you this false sense of awareness saying, oh, I'm fully protected. No, you're not protected. You know, you're protected when you're in the shade enjoying that cruise, when you're putting on protective clothing while enjoying that cruise, when you're putting on the SPF factored broad-based sun protective products, right? So there is a way to have fun and yet not have to subject yourself to a known carcinogen.
Next question. I see a question in the room.
Yes, hi, thank you. So it does seem like the beauty culture, specifically with teenage girls, is going to be one of the hardest to combat. I was guilty of being one of those teenage girls going to prom. Has there been any movement in promoting alternatives, so in promoting spray tanning or any kind of products that sort of fake the tan but are safer? And do we know whether or not they're safer?
So the FDA regulates the ingredients that are in spray tans, but they're not used to be inhaled. And if you've ever been in a spray tanning booth, I haven't, but from what I understand, it's very difficult to avoid inhaling those. So we cannot recommend that as an alternative. I should also say that although we don't specifically recommend it, there are products on the market which can be applied directly to the skin, you know, DIY, over the counter, which may be an alternative for some people. And I think there's also a little bit of debate over, do we sort of recommend alternatives, or do we work on sort of changing social norms so that we're comfortable in the skin that we're in?
Another one from our social media audience. It was mentioned that screening is not recommended for the general public. Should it be recommended for individuals with a large number of risk factors such as pale skin, family history, and a history of many sunburns?
That's a great question to ask your family doctor.
I'm going to step into this one, right? So far, the U.S. Preventive Services Task Force is looking at data, right? As a dermatologist, right, or as a surgical oncologist, we look at data and say, okay, it hasn't been proven to be cost-effective to have everybody screened. And yet, wearing my other hat, I'm a member of the American Academy of Dermatology that every year conducts skin cancer screening as part of their community engagement. I, for the longest time when I was at NIOSH in Cincinnati, did annual screening within our facility there. And so the idea is that we realize that we're waiting on data. In fact, the U.S. Preventive Services Task Force is looking at the recent data from Germany on this, and our hope is there will be some modifications on the screening concept. Until now, because we do believe in the U.S. Preventive Services Task Force and its high criteria of proving what works and what doesn't, what it says about generalized screening is inconclusive. What it says about counseling is conclusive for specific age groups and specific fair-skinned populations. In the clinical world, what you'll see is someone who has had a pre-skin cancer, for example, an actinic keratosis, or more of those, usually there are multiple. Someone who has had a basal cell, squamous cell, or melanoma is oftentimes counseled by their physicians to follow up. Now, there's two roles of sort of routes of following up. One is the self-screening, which is all of you here should be doing that. There is no economic cost associated with that. There's no sense of, of reimbursement. There's no sense of insurance cost, which is get to know your bodies. Get to know your skin. If you have somebody who's not, where it's not problematic for them to check you out, if you know what I mean, have them help you look at the areas you can't see. If not, strategic use of mirrors is great. And all you're doing in this case is, if there's anything that looks kind of weird to you, note it. And there's two routes. Take it to your physician, to your healthcare provider, and say, hey, listen, I noticed this spot. Or, if it's been there for a while, take a photograph of it. Everybody's doing selfies. Do selfies of your lesions, right? And monitor it yourself, right? Which is you're looking for changes in size, shape, color, or symptoms associated with it, signs associated with it. So we have a burden here as well. But certainly anybody who's had a history will oftentimes be consoled, which is follow up with me 6 months from now, a year from now, and in the meantime, monitor anything.
All right, I'd like to thank our speakers/heroes one more time. And all of the materials associated with this session will be posted on the web within the next 72 hours or so. And please join us next month for the next session of CDC Public Health Grand Rounds.